som, 1, 2, som, 1, 2. Um, dois. Um, dois.
Tá aberto esse? Tá ok. Funcionando. Olá, boa noite a todos. Gostaria de agradecer a presença de todos vocês aqui, a participação dos presentes, a participação daqueles que estão via Facebook e via site da Escola Paulista de Urologia. Essa é a nossa 8ª reunião do ano, a reunião clínica que nós fazemos aqui em parceria com o Hospital Moriá. E gostaríamos de agradecer também a equipe do Hospital Moriá pela ajuda e pela parceria nessas reuniões. Nessa reunião também gostaria de agradecer a participação do pessoal da Boston Scientific, que nos ajudou com o patrocínio dessa reunião e também com o nosso convidado. E essa é uma reunião um pouco diferente, a gente não vai ter discussão de casos clínicos, mas teremos a participação de um convidado internacional, que é o Dr. Greg Earle, que estará aqui discutindo com a gente os avanços em relação a green light e terapia a laser para a próstata. Então, gostaria de chamar ao palco aqui o Dr. Greg, que é um médico urologista da Virgínia, da Universidade de Virgínia, nos Estados Unidos. Tem uma vasta experiência com câncer com hiperplasia benigna de próstata, operando próstata laser desde 2003, com cerca de 3.000 casos. E vai participar com a gente aqui, fazendo uma apresentação em relação a laser e avanços para a hiperplasia benigna de próstata. Então, queria convidar ao palco o Dr. Greg Earle, que fará uma apresentação para a gente. Na sequência, nós faremos as perguntas e uma discussão em relação à apresentação, em relação aos casos que ele vai apresentar, tanto via Facebook, via site da Escola Paulista de Urologia. Ok? Professor.
Marcos, obrigado. So, unfortunately, the rest will be in English. So, thank you very much for having me. It's an honor to be here in a beautiful facility. So, those of you who are online don't get to enjoy. But so, I will go through green light. We'll talk about the technology, how it's improved, evolved over the years, and then I have had a lot of experience with it, as Marcos said, and I'll go through some of that, and then we'll talk about technique too and how to get the most out of this laser. So I began doing green light with the 80 watt, the lower power one, in 2003, and we do all of them as an outpatient or day surgery. So the patients go home with a catheter, and we'll talk some more about that. I've done almost 3,000, and most of them with the higher power laser now, and I've gotten to do some clinical trials as well. We won't talk too much about that tonight, but we can touch on that. And really no longer do TURP. So we do have bipolar TURP, but most patients would rather have the green light. They go home the same day and less complication, and we'll try to convince you tonight. So one of the biggest problems that we see with this, and I asked one of our distributors who basically like a distributor in your country, she's seen thousands and thousands of procedures and hundreds of different urologists perform it, and she says really one of the biggest mistakes is that trying to adapt the new technology to your old way of doing the surgery. So in other words, most of us are very good with TURP, but if you don't change how you do the procedure with a laser, you're not going to take advantage of that technology, and we'll talk a lot about that. So the technology itself, it really has evolved over the years, starting back in the mid-1990s, and started with really the first commercial was an 80 watt laser, and then has evolved in 2010 in the US. We got the 180 watt. And they also have a simulator. This was the first simulator that came out. There's actually now a very digital high-tech simulator that if you want some practice doing before learning the procedure, it's very helpful. And this is basically shows the physics and why green light is different. So on this axis is the absorption coefficient, how much laser energy is absorbed. On the x-axis is the laser wavelength. So these are the wavelength is set in the laser itself. And this curve is water, and this curve is oxyhemoglobin or tissue. Excuse me. So we as urologists work underwater with the scope, and we want to deliver that laser energy to the tissue. So we don't want much of it absorbed in the water. We want to transmit it to the tissue where we have the most effect. So if you were going to design the ideal laser for the prostate, you'd want the biggest gap here, space between water and tissue. If you follow these along at this 980, they're very similar. So you have to send a whole lot more energy in to have any effect on the tissue itself, and that leads to more complications. As the curves continue out, and again, this is the physics, this is set, it's not anything to do with the companies. The water curve is now up here. So we take advantage of this with holmium, where there's less effect on the tissue, but more effect in the water, and that's what creates the explosion and blows up the stone. So that's why this laser's holmium is better for stones, but not good for vaporizing prostate. So you say, well, if this is the best for the science, the physics, why doesn't every laser make theirs 532 nanometer for the prostate? Well, they can. It's patent protected. So the green light, the Boston Scientific has that set. So the other thing that really varies with the physics is the depth of the penetration. So with the 532 nanometer, it's just 1 to 2 millimeters. So it's really an optical penetration. You see how far it's going. With some of the others, you send the energy a whole lot deeper, so a lot more irritative symptoms, a lot more side effects. And again, the holmium, these in the 2000 nanometer range, do very well cutting tissue and treating the stone, but they don't do well vaporizing prostate, and there's a lot of bleeding because there's not much coagulation later. So really in the U.S. and many places around the world, the green light is becoming the #1 laser for BPH. So it's by far the most used in the States these days. And a lot of that has to do with the improvements it's gotten over the last years. So the 180 watt now has what's called a moxie fiber. So it's a more durable, sturdy fiber. This is a metal steel cap on it, and it's more efficient and a stronger fiber than what we had before. It maintains its power a lot more than it used to. And it's saline cooled, so we hang a separate liter bag of saline that flushes through the fiber to keep it cool and comes out the laser aperture to keep that part clean, which again helps maintain its strength. The coagulation has improved, and it has a feature called Fiber Life that detects through infrared feedback the temperature in the laser cap. So in other words, if the laser beam hits a stone, that energies bounce back and the cap can heat up and damage the fiber. It starts cutting off and on or flashing to protect the fiber, and if we don't move or change where we're aiming, within 2 seconds it will go on standby, which is again to protect the fiber. And it goes up to 650,000 joules, which will treat 150 gram prostate at least. So that's again much better than what we had before. So you do need a filter in the system to protect the camera from the laser, and I've been fortunate to traveling around pretty much everywhere has had either the stores or the Striker, which I think are better. But if you do have the Olympus, it can look dreadful even with the regular filter, but they now have a filter that corrects that image to make it look better, so not a worry. So shift gears a little bit. How do you evaluate these patients? Again, you urologists in Brazil do very well with this. You have the IPSS, AUA symptom score, PSA when appropriate. You do flows, post-void residual, more formal urodynamics if something doesn't fit. The one thing I guess is different with us, we do flexible cystoscopy on all the patients in the clinic beforehand, so just under local anesthesia, so we're not surprised, no stricture, no tumors in there. But that said, you can get a lot of information from ultrasound in either transrectal or transabdominal. I think that's gotten much better now, and you can get a pretty good accurate prostate volume with transabdominal. So counseling patients, it is important too that the patient understands the expectations, what to expect. And I tell the patients, before they have the surgery, that your symptoms may get worse before they get better. And I think that's important for them to understand they have some healing up to do. And we'd warn them about infection, bleeding, although bleeding is much less than anything else out there. Very low rate of stricture and bladder neck contracture because we're usually using a small or a 23 French scope. I tell them they will get retrograde ejaculation. They don't all, but the majority will. Now that said, we can do what's called ejaculatory sparing or save some tissue over the viru. If you save about 2 millimeters or more of tissue, that can actually help prevent the retrograde ejaculation in most cases, but I don't guarantee the patient that. And we talk about regrowth, which is very low as well if you treat all that transitional tissue. So the operation itself. So I think it's important, these are kind of key steps to how to learn to do it and to get comfortable with it. And just like with any surgery or any sport, the more you do it, the better you get with it. So it is important to be systematic with it. It is important to really maintain control of that field, to know where the anatomy is and where you are. And really, as I get to teach the residents and teaching around the world, it's everything you do with this laser, the goal is to be efficient with your vaporization. So, and we'll spend a lot of time on this, but everything step you take, the goal is to efficiently vaporize that tissue. And really sticking to the fundamentals are important. And just like I said, I try to play tennis, and the fundamentals, if you don't watch the ball, bend your knees, rotate, you can't hit Roger Federer forehands, but we like to skip over that boring stuff and go right to trying to kill the ball. So you've got to do the fundamentals to get the outcomes that you want. So a group of urologists in the U.S. got together to help. It was American Medical Systems at the time, and now Boston Scientific, to come up with principles how to effectively or most efficiently vaporize. So what are steps that all of us agree that are important to do to get the best outcomes? And these are really the fundamentals that we agreed on. So that fiber to tissue distance, how close you have the laser fiber to the tissue, and we'll talk about each of these ad nauseum. The sweep speed, how quick you rotate that fiber back and forth, and again, different from TURP. The sweep arc, you don't want to sweep very wide, but just a tight arc to keep that delivering the energy the way you want in the tissue. And the power setting, how high up you turn that laser and when. And again, those are all very important to get the best outcomes with it. And then the other just sort of side is you take advantage of, it's a continuous flow scope that we use, so we keep the bladder generally pretty full, and it helps decrease some of that venous bleeding, and helps with the visibility, again, because you're using a smaller scope. So I think this is very important to understand that when you're stepping on the pedal, you're delivering energy to that tissue, and if you're not getting the tissue above 100 degrees centigrade, you're coagulating. Even if you're stepping on the vaporized pedal, and it's just like TURP, there's a vaporized and a coagulation pedal, but if you're on the vaporized pedal and you're not getting the tissue hot enough, you're inadvertently coagulating, and that's where the tremble comes. Again, the goal with this is to get that temperature to 100 degrees centigrade. So we're working underwater, and if tissue gets to 100 degrees, it's going to vaporize, turns into a gas. Well, underwater, a gas is a bubble. So the more bubbles, the bigger bubbles you see, the more efficient your vaporization is. And again, that's very important to remember. So this basically just says, being systematic, given a procedure, you're going to get the best outcomes. So repeatable practice, just like anything, you're going to get the best outcome and happiest patients. So these are those 9 steps that we agreed on, and then I'll go through each of these. I won't read through all of them now, but again, it's important to address these, to go through these steps to get what you want out of the procedure. So the first 3 are easy, and as talented urologists, you do this. You careful putting the scope in. There's actually a visual obturator, but you don't want to get the tissue bleeding. It's hard to see up front. So gently putting the scope in, looking at the shape of the prostate from within, and if you haven't been able to scope the patient before, what that median lobe looks like, how high up the bladder neck is, where the viru montanum is, and then where the ureteral orifice are. And sometimes on the big prostate and the big median lobe, you actually can't see the ureteral orifices at first, and that's okay. But again, you can see where they're not to start the procedure. So you want to see that aiming beam when you step on the ready pedal to know that you're hitting prostate tissue and not within the bladder. And again, if you haven't seen the ureteral orifices yet, you can start further in for safety. And all of us agree that it's really best to start at that low wattage to 80 watts because you get a little more coagulation effect. Sorry about that. And you actually are going to get less bleeding with it as you advance through the procedure. And then this talks about, too, the efficient vaporization. So one of my good friends, Ricardo Gonzalez, came up with this. Not only do you want to see bubbles, but you want to see bigger bubbles. As a scuba diver, the big bubbles are the sign that you're efficiently vaporizing. If you see the smaller champagne-like bubbles, that's good for your champagne, but not so much for treating the prostate. So you want those bigger bubbles to be vaporizing better. And then again, I think this laser fiber is cooled, and with our flow, the saline irrigation that we use, and we're creating these bubbles. We want those to flush forward into the bladder. So the best way to accomplish that is to open that bladder neck, and best done that by lasering at 5 and 7 o'clock. So at that 5 o'clock point at the bladder neck and 7 o'clock, if you sweep and cut grooves going back to the viru, that will drop your bladder neck and really help the view and help the flow going forward. And if you need more power, that's okay to increase up to 120 watt. And I usually go 80 watt, 120, sometimes 150, and 180. Sometimes we'll skip right to 180 watt. But not at first. At first you want to create that channel and work with the lower power to you get a little more coagulation effect because most of your bleeding is in that mucosal layer. So make your incisions at 5 and 7 o'clock. And again, remember the factors that influence that vaporization are your sweep speed, how close you are to the tissue, and then the power you're using. And again, we've said this, I'll just say in a little different way, you know, the bubbles are the feedback you want. So you're going to get to the point once you're comfortable with the moves is your eyes, your computer are going to see whether you're creating bubbles. And if you're working and not seeing the bubbles, then you go through that checklist. You know, am I sweeping too fast? Am I too far from the tissue? Or do I just need to increase the power? And if you're not seeing the bubbles, then that's where you get into trouble. And that's, you're going to create more coagulation effect. It's going to send the energy deeper into the tissue. It's not vaporizing it. You're going to get more edema and more post-op problems. And we'll talk some more about that as well. So the median lobe, this is a very good device to treat median lobes. When you make that 5 and 7 o'clock groove, that demarcates what median lobe is there. And then if it's a large median lobe, like the case we had day before yesterday, or Friday, make a groove at 6 o'clock as well, and that can make it a little easier to handle that bigger median lobe. And you can actually cut off tissue if you want, if you wanted to send to pathology, but it's just as fast, or I think faster, just to vaporize. But again, works very well. Coming in on the side of that median lobe so you're not sending the energy deep can work better also. So I told you most of the bleedings early on. If you create a channel at that lower wattage, 80 to 120 watts, then you essentially treat that first millimeter to depth of tissue to help control the bleeding, and work from the bladder neck back towards the apex, again, to help open that up to help your view. It's important to be systematic with it as well, and that's the step 7. So if you are laser and you start over here, you get some bleeding, you say, I'm going to go over here, then get that bleeding, then come down here, get that bleeding, you're going to be lost. It's very frustrating. And again, you have a smaller scope, less flow. So if you're working here and you get bleeding, it's important to try to control that before you move on so you don't lose your visibility. And typically not with the coag pedal. So I joke with my residents, it's actually a sign of weakness to step on the coag, that you want to be able to use that laser to control it. So if it's an arterial pumping bleeder, that's usually pretty easy. You can vaporize around that and it'll seal it off. And just like with TURP, when you get bleeding, the teaching was to keep working towards the capsule and you'll control it. If it's more of a venous kind of thing, usually just working around and through that will cover it as well. You don't want to laser right into a lot of red because it'll absorb the energy, as we saw in that other graph. So you may need the scope or the fiber to compress the tissue, see where the bleeding is, and then treat that tissue around it. And then the other thing that's a little different than TURP, and I mentioned here, is lasering up and down that lateral wall. So with TURP, you cut grooves the whole way. We said we start with grooves at 5 and 7, and then 1 and 11 can help as well. But then going up and down the side tends to, I think, help with the visibility, the control of bleeding, and your better outcomes. So increasing the power. So with if it's a 60 gram gland or greater, my goal is to get to that 180 watt to take advantage of the power and the effect the laser has. So you create that channel at the lower wattage and increase the power as needed. And we mentioned here, if it's a decent sized prostate, making that a groove at 1 and 11 o'clock can help as well. And that's usually the thinnest part, and if you start to find some capsule there, then it can really help you kind of carve out the prostate, if you will, and it should look like a nice TUR defect when you're done. And again, you don't want to dig a hole in one area, but you want to go up and down and make some progress back towards the apex to circumferentially open that channel up. Once you've done your grooves, 5 and 7, your median lobe, and then your lateral lobes, then you can address any anterior tissue if you haven't taken care of that already. And again, there's usually tissue up there, but usually not a whole lot, and you want to be careful. You don't want to go too deep there. And then the last step is the apical tissue. And again, On this one, you can see viru here, and then here's some lateral lobe, and that looks like adenoma. This is a bigger prostate, so you can actually come beyond viru. And the laser, I think, is nice. You can really fine-tune what tissue you want to take or leave. Here, we've continued to laser. Now, I'll admit this was not my picture. They have hit the viru a little bit there, but if you touch it on there, it can cause a little burn with that, but that'll heal up fine. It'll be okay. But again, vaporizing this apical tissue, you can be very precise with it and work around the corner a little bit. I had done lasers for a number of years, and I would get to look back in patients who had some bleeding or bladder tumor, and I'd look in, the bladder neck would be wide open, the middle part of the gland would be wide open, but there'd be all this tissue at the apex. And I think what was happening, I just wasn't taking enough here or going around the corner, if you will, to vaporize that tissue so it didn't fall in. And then step 9, really completing the procedure. So it should be a nice open defect, and we'll show you some pictures here in a little bit, but you get rid of tissue. You get rid of 50 to 70% of that prostate volume. We've gone back and on some of the clinical trials and re-ultrasounded patients that we could convince to do that. And plus the PSA should drop as well. So we'll usually get another PSA at 3 to 4 months out, and that's, again, a good monitor of prostate volume. And it should drop by half. And then the reigning fossa should really look pretty smooth, and I'll show you a better picture of this in a little bit. So although it looks fuzzy at first, it has no effect. If you've vaporized well and haven't coagulated or damaged that tissue too much, it will heal over nicely. So at the end, you want to make sure your renal orifices are okay. If you do accidentally get one, you're not damaging very deep, so you can usually stent and that patient will be fine, but it's important to recognize that. You want to make sure there's no arterial bleeding or nothing pumping. So unlike a TURP, at the end you spend time chasing bleeders and chasing chips. At the end of this, you make sure nothing arterial is bleeding. You cut off the flow, but I typically don't drain the bladder and then look back in because it's just going to be red everywhere. And that's because you've taken pressure off by decompressing that bladder. Those venous channels can be open, and it can be very scary looking at that point. So what we've gotten to do now, since the patient is going home, I don't typically use a 3-way catheter. If I was going to keep him in the hospital, I think that's fine. But we actually will give Lasix or Lasix, the diuretic, about 10 minutes before you think you're finished with the procedure. And that works very well to basically irrigate from within. And again, these are usually older patients, and they're better off with less fluid on board than more. So although they don't absorb a lot of fluid with this procedure, I think the Lasix really helps irrigate and keeps that catheter from clotting off early on. And I think the other thing with that venous bleeding, if it is very red at the end, you decompress the bladder, put the patient's legs down, put the catheter in. I think there's some decompression of that capsule, and the bleeding will usually stop at that point. But the Lasix will help prevent clotting early on. And I'll typically use just a 20 French Foley, the 2-way. I do use a big balloon. I use a 30 cc balloon, and I'll actually overfill that. I'll put 45 cc's in there. But typically that's coming out the next day. If it's a bigger prostate or they're on anticoagulant, then I will use the 22 French catheter. So this is the thing, a lot of doctors who've tried laser in the past were very frustrated because there were a lot of irritative symptoms. I'll get asked that question all the time, how do you prevent that? Well, really the best way to avoid those is by the technique that we've talked about. So again, very efficient vaporization. You want to be close to the tissue, sweep speed, tight sweep arc. Make sure you have enough power and vaporize to the capsule. Keep going out and getting rid of that tissue. And I'll spend a little time kind of going through the little more detail with these. So you say be close to tissue. Well, how close? What does that mean? So the fiber is 2.1 millimeters diameter, about 2 millimeters you can remember. So if you're 1 fiber cap from the tissue, you're in a good space. I honestly think the closer the better. So as you vaporize tissue, that tissue is going to disappear. So you've got to keep moving down or chase the tissue, if you will. But it ideally close. So this is a little cartoon that shows in the working distance. So if you're too far, you're just coagulating that tissue and no bubbles. If you're closer, you at least get the smaller bubbles, but still some coagulation. If you get closer to that tissue, 1 fiber distance, you heat that tissue better to 100 degrees centigrade, saw the big bubbles, and not damaging that tissue much. So sweep speed, so 2 to 3 millimeters per second is the recommendation. And again, you're delivering that energy to the tissue, so you want to heat the tissue. If you're sweeping too fast, it's not going to heat up as well. And this little schematic shows that. If you're sweeping too fast, more coagulation, more edema of the tissue. If you slow that sweep speed down, you get bigger bubbles, more effective, more efficient vaporization. And that's what I talked about. As the tissue disappears, you've got to move down to get it, to chase that tissue, and moving up and down the side. Sweep arc. So we say no more than 2 numbers on the clock. And what do we mean by that? So if you sweep real wide, you're too far from the tissue out here, so you're going to be damaging that more coagulation, more edema. So you want to make that sweep arc tighter, no more than 2 numbers on the clock, to get the most efficient effect. Good. And then this is what it looks like in real life. So this is the fiber. You can see the tip of the fiber. We're keeping it pretty the same distance from the tip of the scope, and this is cutting basically a groove at 7 o'clock. But you can see a nice slow sweep there. You can see big bubbles. They're briefly in your way, but they flush forward and float forward into the bladder. And that's basically all there is to it. You take advantage of that power that the laser has to melt that tissue away. And you see it's not black or charred, so you're not coagulating or damaging it. You're melting away what you want to. So more power means more efficient vaporization, but you're not sending the energy any deeper, and that's important to remember. So a lot of doctors are afraid that I don't want to turn up the power because it's more dangerous. Well, actually, it's probably the other way around. If you don't turn up enough power, you're going to have more irritative symptoms. You're not going to get rid of the tissue you want, and bad outcomes. So turn up that power when you need to, when you can and need to. You're not sending the energy any deeper if you're efficiently vaporizing. And this just looks at the difference in the power. So that's 80 watt. You're getting some coagulation effect. The bubbles aren't quite as big. When you go to 120 watt, bigger bubbles, a little less coagulation. And then when you go to 180 watt, it gets rid of the tissue much faster, bigger bubbles, and basically you want to take advantage of that. So these surgeries are quicker. I can definitely do this faster than I could a TURP. And once you start doing some of those, you will as well. Now this is again in a real patient. You can see the difference in the 120 watt, 150 watt, and 180 watt. So the difference in what the bubbles look like and how much tissue you get rid of in a short amount of time. So I think it is important, too, to vaporize to the capsule, just like, I was taught, and you're probably taught with TURPs, the working deeper to get to that surgical capsule, you're going to have more durable results, less problems down the road, you're going to have better outcomes, you're going to have much less regrowth. I think if you get rid of all that transition zone tissue, there's nothing to grow back there, and you're going to get happier patients telling their friends and more referrals to get to do more surgeries. And this looks at vaporizing into the capsule. So you'll see here, that's pretty thin looking, almost Swiss cheese kind of look. There's some tissue there, and you can see we're pretty deep to capsule further in towards the bladder neck. And it just has a different appearance, more smooth looking than that other area. And I'll show you another example. And this is what it should look like towards the end of the procedure. So this is the irrigation still on at this point. You can see no chips really, just sort of debris that floats around, and that'll easily irrigate out when you drain the bladder. You don't have to use a syringe or do any kind of special irrigation with it usually. And then here you can see a little better looking capsule stuff. So pretty smooth, few little fronds there. They won't harm anything. It will heal over, as I'll show you. And again, looking at his right side, and that's pretty open fossa. And now that's with water off. So there's nothing arterial bleeding. There's a little bit of ooze up here that I typically wouldn't do anything to, but I'll show you what you can do if you want. If this is an anticoagulated patient, somebody that I was more worried about, I would maybe just coagulate. Now you can see, you say, well, I'm too far from tissue and I'm sweeping very fast. That's on purpose, so I want to coagulate now. So that's stepping on the vaporize pedal, but it's just sweeping very fast and further from the tissue to take advantage of the coagulation to coagulate that little venous bleeding area. And it controlled that fairly well there. So, but no chasing bleeders like your TUR at the end, no chasing chips, you're done. So the other thing that comes up is bleeding, and really the most of the bleeding you encounter is early and late. So early is that mucosal area, especially if the patient's been in retention, has had a catheter in, has had a UTI, it's just going to be more friable, and you've just got to be patient and vaporize through that at the lower wattage. And really you just kind of work around and through it. You know you're not at capsule, you just got to get rid of that tissue, and that bleeding will control itself most all the time. Usually in the middle of the case there's not much bleeding, and then the other time you encountered it is late. So when you get to that surgical capsule, you get more into the venous sinuses. Generally they don't do well with coagulation. You don't want to aim in them, you're just going to make a bigger hole. So you can sometimes vaporize around, but if that just makes it worse, you're better just to put a catheter in, put them on traction, irrigation, and it's going to stop. So the other thing that always comes up in the U.S., it seems like almost every patient's on an anticoagulant. So if you can stop those before the surgery, I think that helps. So, and it's a whole spectrum. The Plavix is my least favorite. I think it has a bad impact on the platelets. It can last. So if I can get a patient off Plavix, ideally 10 days beforehand, but as long as I can. Whereas aspirin, I think a baby aspirin has very, very little effect, and they can stay on that even. Full strength aspirin is different, but baby aspirin. So then all the others in between, if the patient stop their anticoagulant for their hernia surgery, their cataract surgery, then I want a window off to do this surgery. If not, you can do them on the anticoagulant. Usually you don't have any more bleeding during the procedure, but they're definitely going to bleed more afterwards, and you have to, keep that in mind. So again, the key, start with lower wattage to help control that bleeding. And as we said, don't depend on the coag pedal. You're going to get very frustrated. It's not like a TUR loop putting on there and it instantly coagulates it. You occasionally use the coag, as I showed you that time, but honestly we use it probably less than 5% of cases. So vaporizing through into the capsule, just like with a TURP. And it is important to stop that arterial bleeding. So if it's a pumper, you want to control that. That needs to be vaporized and controlled, and it usually can be pretty easily by painting around it. If it's venous bleeding, again, we've said it's going to stop. It's generally not as bad as you think. When you first start learning, if you're using the 23 scope, you see bleeding, you get frustrated, you ask for the resectoscope. By the time they get it there, you take your scope out, look in, it's already stopped bleeding. So again, that venous is going to stop on its own. Using the Lasix, I think, really helps. Raising the irrigant so you have more flow coming through to keep the flow and the visibility there. This is a nice little trick that we use probably less than 2% of the time, but you probably used a bug bee or have a bug bee. They actually have a bipolar bug bee now, and I should put bipolar in there. But so you're using saline for your laser. You can put the laser on standby, take the laser fiber out, and this is a reusable bug bee. Wolf makes one and Stores make one. It's a metal device. It kind of looks like the laser fiber. You put that in, it hooks to any generator coagulation box you have, and you can nicely pinpoint if you get a whole nest of bleeders or frustrating area. The bug bee can work very well for that. So you coagulate those, take that out, and then put your laser fiber back in. For the venous bleeding, traction works well. Again, don't have to use it very often, but especially if you're keeping it in the hospital, there's no problem doing that. And then I may have them keep the catheter longer. So again, we send them home with the catheter, and we teach the patient to take it out themselves, believe it or not. So they get a instruction sheet, pictures, and if they just can't fathom doing that, they can come in the clinic and we'll do it. But we encourage them. It saves you a trip. You know, don't have to fight the traffic. You take the catheter out in the morning. Then if there's any trouble, we're in the clinic in the daytime. But we've had a few disasters in the past, but for the most part, it works well. And so we tell them, you know, tomorrow morning, if the urine is clear in the tubing, you're feeling okay, take that catheter out. If it's still a little bloody or you're moving slow, it won't hurt to leave it another day. But again, out in the morning's best, so we can help out. So you can do very large glands with this laser. I've done a few up in the 500 gram range. It's probably not ideal for that, but again, these were patients that anticoagulated and didn't really have many other options. But I've done many in the 200 gram range, 100 to 200 grams, and you can typically do with one fiber, less than 2 hours. They go home the same day and not much bleeding with it. I didn't have this when I was first starting doing them, but if you start doing big glands, you can use a resectoscope. You get better flow, better visibility, and if you're worried, you can always put in a loop or coagulate it, again, just to have as an insurance backup. But the bigger scope allows you better flow, and there's a laser bridge that all the scopes have that will hold the fiber still and doesn't obstruct your flow. With the big ones, it's very important to be systematic, not to get bleeding in somewhere and move on somewhere else. So if you're working along and all of a sudden it turns red, well, you know that bleeding had to come somewhere within here where you're working. And again, just those 9 steps we went through, if you stick to that, to those fundamentals, you're going to get good outcomes with it. So kind of winding down what we do post-op, we talked about just a catheter 1 to 2 nights. We send them all home and teach the patient to remove themselves. But again, if you keep them in-house, usually just overnight is fine. We'll give them a phone call that first week to see how they're doing, and then usually follow them up in the clinic in 3 to 4 weeks. We'll get a urine culture and a post-void residual, so make sure they're empty and okay. And then we'll see them back in about 3 or 4 months. At that visit, we'll get a PSA and then try to get a flow and a post-void residual. The PSA, again, is nice. That'll be their new baseline, so it should be at least half or more less than what their original was. And then at that point, we will release them from our service. I mean, again, they shouldn't have more problems. They shouldn't need to come back. If they do, they can, but again, we send them back to the primary care and come back only if you need to, and that opens space for new patients. We do continue to follow them, though, if they have the OAB or overactive bladder. We'll talk some more about that. So this is a patient 3.5 years out, and you can see how it just heals over. There's just a little bit of tissue right there on the floor, but you can see pretty open bladder neck and pretty level and very smooth looking tissue. And that's, with water off, there's no collapsing. It's a good open channel. So the complications, I've made it sound so good, but when there are trouble, it's usually pretty easy to manage. So, and that's why I've gone to doing these. It's less taking patients back for bleeding, less hassle, less phone calls. The patients, generally, it is easier on them. So again, if they do get some dysuria, the burning, the best way to treat that is to prevent it. So sticking with those fundamentals like we talked about. And the other things, overactive bladder, that frequency, urgency, that's different than the dysuria we'll talk about. Diminished flow. So when they come back, that's the first thing I'll ask them, about the flow. And we'll go through each of these: incontinence and bleeding. So the dysuria, again, prevent with a good technique. Distance to tissue, slow sweep speed, tight sweep arc, increase your power, and work to the capsule. If they do have some dysuria, the younger patient, big median lobe, it's going to be more sensitive. You can use Pyridium, which I know you all have. Uropeu is a similar thing we have. A non-steroidal, like an ibuprofen, that works well especially if they have some pelvic pressure discomfort, because they do get some inflammatory reaction from this, some more than others. If there's a lot of irritation, a lot of inflammation, or you maybe inadvertently coagulated too much, you can use a low dose of Medrol or a steroid dose pack, like a 6-7 day course. Now this is very rare, and I haven't done in the last couple of years, but it can help. It's the best anti-inflammatory. We really try to avoid the narcotics, and that's a big thing in the U.S. now. Narcotics are now bad. Used to, they'd want us to give every post-op patient. Now they're wanting to avoid. I do give them a stool softener just because I don't want them constipated or straining to go, putting extra pressure. And then if they are having the burn and discomfort, they're welcome to come in the clinic. We'll make sure they don't have a UTI. And you can release some bacteria from the prostate sometimes, so it's important to treat an infection if it's there. So the next one on the list, OAB, the frequency urgency. Again, different from dysuria, frequency and urgency. And what I think happens is we often unmask that overactive bladder. And I describe it to patients: your bladder's a muscular sac, basically two functions. It stores urine and it empties. And like any muscle, if you use it a lot, it first gets bigger. If you overuse it, you can burn it out. And that's what we don't want to happen, and that's why you tell the patient they may need the surgery and the pills aren't working anymore. So if they do have that overactive bladder pre-op, they're going to have that post-op, and it may get worse before it gets better. But again, their bladder was working really hard, forcing urine through the blockage. Now the blockage is gone, the bladder's overactive. So most of the time it's going to get better on its own. The more severe, the older the patient, the less likely that may completely resolve. But again, it's very important for the patient to understand that before the surgery. And then we very aggressively treat. You can use the anticholinergics. I have a low threshold to use those. And also I think it's important for the patient to understand if you didn't unblock that bladder, it was only going to get worse and eventually burn out and not work. And again, you've got other treatment options, Botox, InterStim, those kind of things if the pills don't work. So these next three, diminished flow. So when the patient comes back, the first thing we ask is, do you have a good strong stream when your bladder's full? And if they have that, then everything else is going to work out. Now, if they don't have a strong flow, then you start to worry either the bladder is not contracting well, was weak, and you missed that in the workup, or there's a blockage in there. If there's a piece of tissue that's sloughed off, which doesn't happen much, but when you're learning that can happen, usually stricture or bladder neck contracture occurs later, so that's not going to happen early on. But again, and that's the patient who initially did well, then comes back 6 months to a year later and says, "Doctor, I was doing great, but now my symptoms have come back." That's when you want to scope and make sure they don't have some scar in there. Incontinence, stress incontinence is fairly rare, less than HOLEP for sure. You can kind of predict if it's an older patient, if they're in retention, you're very aggressive at the apex, then you can give them some usually temporary stress incontinence. It's very unusual to create bad stress incontinence because, again, it's just how much tissue you take at the apex, I think, is the main factor there. If they do have some pelvic floor dysfunction, physical therapy, you can help with that. Urge is different. A lot of them have some urge incontinence preoperatively if you really ask them. And again, it goes with that overactive bladder that you're treating that. So again, if they have the urge incontinence, it's important to differentiate that, to make sure you know what that is. And that's a different treatment. That's with the medicines to relax the bladder. And then bleeding. Again, a lot less bleeding with this than any of the other BPH procedures, but the first thing, just increase fluids and decreased activity. So we tell the patient it's a raw surface, it has to heal. If you're doing too much too soon, you may have more bleeding, delay your healing, and so give it some time to heal up. But they do get back to regular activity pretty quick, and quicker than TURP, I think. If they're on an anticoagulant and they started that back, you can stop that to, again, give it some time to heal. May have to replace the catheter, that's pretty rare. For that delayed bleeding, say months or even years later, if some tissue starts to grow back, then finasteride, Proscar, works very well for that, to drop those blood vessels, and that's a good thing to use when you need. So really winding down now, it really is a new paradigm for the older patient. They see this as a more minimally invasive outpatient procedure, more rapid recovery, can get them off their medicines and really improve the quality of life, which I think as we're living longer, it's important to take advantage of this to really take advantage of good quality of life. And in summary, we talked about proper patient and OR preparation, and really stressed a lot about the fundamentals, the distance to the tissue, sweep speed, sweep arc, and then what you're turning that power up to, and just being systematic, those steps you go through to accomplish the goal that you want. So thank you very much for your time and attention. I really appreciate it. Thank you. So happy to take some questions.
So first of all, I would like to thank Dr. Greg for his nice presentation. It was very good for us. Vocês querem fazer alguma pergunta diretamente para ele, para que a gente possa dar andamento?
Regarding the time of vaporization, what concerns to urethral and bladder neck strictures, what do you consider the main key points of your choice, in contrast, in spite of another minimally invasive techniques?
You mean as far as ask again?
As a prostate volume.
Oh, well.
Because of the time of vaporization, I mean.
Oh, time of vaporization. Well, there's no danger in the vaporization. So the question is, how do you choose which BPH procedure? Do you worry about vaporizing too long? So you have much less absorption of fluid with the green light laser with vaporizing than you do with TURP, and even with bipolar. And there have been a number of studies that showed that. With the vaporization, you're creating that real thin layer of coagulation. So if you're doing it correctly, you're not sending energy deep. They don't get erectile dysfunction. So you're not damaging the nerves. You're not sending that energy outside the prostate, which, at least in the U.S., is a very big selling point to the patients. Patients in the U.S. Don't want TURP. It's a last resort. They have to go into retention. They have to be drug in by their wife to sign up for the operation, whereas they will come say, okay, I will do the laser procedure, easier recovery, usually less than an hour, without much in the way of complications. So the vaporization I don't worry about, and the occurrence of stricture and bladder neck contracture is much less than with any of the other procedures too. So we looked at AMS picked 3 of us, and then we picked 2 other doctors. So 5 of us from North America looked at each of our first 200 patients with the XPS, and those were the first patients. And a separate group looked at them, so it wasn't just us making up the data. And out of my 200 patients, I had 1, and that was over 3.5, almost 4-year time. I had 1 bladder neck contracture out of 200, had no stricture. So I think that comes from that this is a pretty atraumatic procedure. It's a smaller scope, so you rarely have to dilate the urethra and causing less issue. Plus, you're not getting much bladder neck contracture. I'm very aggressive at the bladder neck, but I'm not sending that energy deeper. I'm not scarring that tissue to create the bladder neck contracture. We had one of our residents look back before that study who was getting bladder neck contracture, and although it was less than 2%, you could predict it was a patient with a smaller prostate, poor bladder function, as you know, and oftentimes it had something else done to the prostate, so more likely for that tissue to scar. So those, I may leave the catheter in longer, or and just watch out for it more. But yeah, that's one of the beauties of this: no ED, less stricture, rare stricture, and very little bladder neck contracture.
Okay, thank you. Another question: the fact of being side firing laser fiber, in contrast to an end firing fiber, it would be a disadvantage because it can mean a loss of about 20% of the energy.
So the difference in fire and side fire, well, I would argue against. So we're looking in the prostate, and the tissue we want to get rid of is on the sides. So I would think you'd want a side firing fiber. There's no way with an in firing fiber you can get all that apical tissue and get around the corner to get that. And remember that picture I showed you, and I told you that when I first started doing them, I wasn't treating enough apical tissue. With an in-fire fiber, there's no way I could get the scope there to treat that. Now you can with HOLEP. I think HOLEP is a great operation, but I jokingly say you make an easy operation hard. So it takes twice as long, more complication, very steep learning curve. If we didn't have green light, then I'd say, okay, let's do some HOLEPs, especially on big glands. But I'm not convinced. I mean, I don't need it. And if you do this right, I think there's some doctors who do a very good job with HOLEP, but at least in the U.S., it's a very small number. And we've seen very, very bad complications from it. So that, that's in-firing, and that's cutting. So I think if you're going to cut tissue, in-fire is the best. But if you're going to vaporize, you want to work on the side. And it's not exactly 90 degrees. It shoots forward 70 degrees, so it's a little bit forward angle with it. But you don't lose any energy with this one. With the others, you're right, you do. But that's why these laser boxes cost so much, because if you lift the hood, it's a Ferrari engine in there. There's multiple mirrors and multiple steps so there's no fall off on that laser energy. There is with the others. You're exactly right.
What is your limit in terms of size of the prostate? You said something around 200 grams, but what is your limit in your practice?
Yeah, Marcos, that's a good question. I mean, I don't really have a limit. As you know, with when they get big, it's harder to measure the volume, and usually if a prostate gets much over 100 grams, if it has much median lobe, they'll go into retention. So the 200-gram prostate, he probably doesn't have much median lobe because he wouldn't have grown to 200 grams. So he's just a lot of lateral lobe. And they're actually pretty easy to treat with this. You just can park at the viru and just, and work your way back and just go up and down the sides and really open that up. So if a patient has a very, very large prostate, we counsel them. We can do laser if, say, it's a 300-gram. So I think over 300 grams is very met with ultrasound. So CT or MRI is actually more accurate. But I do like to know how big it is before going in, because you know how long the case is going to take, what to expect. So say a patient has 300 grams. I will tell him we can do laser. I will vaporize for 2 hours. We will get rid of a whole lot of tissue. We can, if we go in and we start getting some bleeding, we may just do one lobe. So vaporize a whole lot of that, say, one lobe, leave the other one, and then if they have more trouble, we can do another stage down the road. I've done that a few times. The last patient I did had a very large bladder stone. That was kind of a surprise. He had been sent to me by somebody else, and 2 very large lateral lobes. So we did his bladder stone and then did one lobe. He did great. He was in retention. He did great until about 3 years later he came back and said, my symptoms are coming back. You told me to call you, and we would do the other lobe. We did, and he's now a year out and, done well, very happy. So, it is 2 operations, but again, it was, outpatient and very easy, no complications on him. So I do think, though, open prostatectomy is great. Just in the U.S., you can't talk a patient into doing that. They just, even if you say this is the best for you, they'll say, okay, they go home, they go on internet or, Google MD, and they come back and say, no, I want something else. I don't want that open operation. So I'd mentioned to you before, one of my partners, we do a lot of Da Vinci's, and so he'll do a simple Da Vinci prostatectomy. And they do well. We've done some patients in their 80s, 300 to 500 gram prostates, and generally just a day or 2 in the hospital. It's a little more of an operation, but it's very effective for that very, very large gland.
Alguma outra pergunta? In terms of results and the satisfaction of the patients, do you have any results?
Well, not that I could pull up quickly. I've been doing them for 18 years, and it's we're not as big as Sao Paulo. It's a pretty small community. So if I wasn't doing well and the patients weren't doing well, I wouldn't keep getting more patients coming back. So I think that's the best proof. But we presented some patient outcomes at the EAU 2 years ago, those 1,000 patients. So they're, to Boston Scientific and American Medical Systems credit, they've sponsored a lot of patient outcome kind of trials. So, as you know, there's a cost for going back and looking at that and having a third party look at it. But we have done that enough to know that it's done very well. So again, no erectile dysfunction, stricture rate is less than 1%, bladder neck contracture less than 2%, redo rate less than 5%, and especially with the higher power laser, much less redo with that. 70% retrograde ejaculation, but again, I tell them that's a sign we did a good operation. We've opened things up. We can try to spare that if they want. The goal is to get them off their medicine, so the only ones that stay on medicine are those who are on finasteride or Proscar for prostate cancer prevention or hair growth if they want for that. But the goal is to get them off the medicine and get them back to their primary care doctor.
Great.
Yeah.
Congratulations on the presentation.
No, thank you.
And is there any kind of financial advantage to the doctor to do laser than TURP?
Right.
In the US?
That's a great question. It's actually the opposite. So I would get paid more if I did a TURP. It's messed up. We have a very dysfunctional healthcare system, as you may see on the news. So because laser's newer, they just started paying less for it. So I would get, I think it's $50 to $100 more if I did a TURP, but I think it's better for the patient, and that's why I do it. And it's easier on me afterwards because you never take them back for bleeding. You're never going back, and that's another thing. I can't think of the last patient that had to go back to the operating room for bleeding with green light. It was over 10 years ago. It's very, very rare. Now, sometimes you have to put a catheter in or irrigate, but again, not having to go back unless, years later is a bladder tumor or something else. But that post-op bleeding stuff you just don't get with this. So yeah, it's less hassle for me, even though I get paid a little less for it, and I'm not having to go to the hospital to see that patient the next day. So in that sense, it's unfortunate because I think that keeps a lot of doctors from adopting green light in the U.S. because the insurance pays for it. In our system, it's actually cheaper for the hospital to do green light because the patient's going home, they're not getting admitted, and so our hospital bed is very expensive, and our resources, our staffing is very expensive. So if you can avoid that, it's cheaper. But our system, you would think, should pay a little bit more to encourage doctors. Okay, I'll learn this new technology. I'll go through the learning curve. I'll start doing this because it's better. But we don't have that. So.
Thank you.
Mm-hmm. That's a good question.
Is there another technique, change in the technique, if there's a huge median lobe that goes into the bladder? Yeah,
good question. Like huge median lobe. So I think you don't want to do your first, 5 or 10 cases with that one. Get comfortable with the smaller glands first. And it's funny, when I started doing them 18 years ago, even the teaching then, Laserscope owned the technology then, and they said start with small glands, not in retention, not anticoagulated, get the technique down, and then do bigger cases. I thought, well, I'm very good. I've done other lasers. I can do hard glands. Big mistake. I had a lot of bleeding, retention, had to go back to the OR. It was not good. I went to a meeting. It was in Greece, very nice place, and I was presenting something else, a BPH, and one of the doctors, Alex Tay, who had done a lot at Cornell, he'd already published some on green light. I said, Alex, what's with your laser? I don't think it works very well. He said, go back, do small glands, get comfortable with it, and then you can get more challenging cases. And he was right. I almost gave up on it and didn't think the laser worked well. So that big median lobe, again, I think it works best to drop 5 and 7 o'clock and then just come right down at 6 o'clock. Even if it's protruding into the bladder, you may not even have seen ureteral orifices, but when you come down that middle part there and drops things down, then you can usually see the ureteral orifices then. And then you can come in with your scope in the bladder and turn sideways, and using that side firing laser can melt it away coming in the sides. So you're not shooting at the ureteral orifices even though you're in the bladder. But you can, I don't really have a video showing that, but you can get right on top of that tissue and really melt it away. You can enucleate, you can cut it out too, but it's very easy to vaporize with that, using that technique there.
There's a question from Facebook. So, okay. Do you have an experience with patients with neuropathic pain after the procedure, and how do you manage it, if you have them?
Yeah, I have not had any patients with neuropathic pain. The chronic prostatitis patient or the chronic pelvic pain, they're difficult patients. But if say a chronic pelvic pain patient has also BPH, which as they age they can get that, that's the patient I would do urodynamics. I would make sure there was obstruction before I did any operation. They would have to be begging me for the operation. That said, those patients have done better, at least anecdotally. Most of them, it does help with the pain, surely helps with the obstructive symptoms, but whether it's getting rid of those glands, some of the adenoma, then you can send them to physical therapy if need be. We've got an excellent physical therapy, but I haven't had any that we've caused neuropathic pain. It's funny, recently I did have one patient who had great results. He was in near retention, high residuals. He came back doing great, but he was complaining of this pain, and he seemed legitimate patient, and I worried, followed, and there have been reports of if you laser through the prostate and again coagulate too much, you can actually get some inflammation or infection of the pelvic, the pubic bone. So I worried about that. CT, fine, no issue there, but he kept with the pain. So I took him back, scoped him, and it was had probably perforated, and there was a little it looked like maybe a pocket, but then I did a retrograde urethrogram, nothing filled, there was no extravasation. I just coagulated that area. It was like just poor healing. So I resected, coagulated that area, and he did great. So, I mean, that's the closest I've had to neuropathic pain. I'm still not sure what caused his pain there, but fortunately it went away.
I have a couple of questions.
Sure.
In regards to overactive bladder symptoms after the procedure, how do you compare the system over the years? Do you think that the earlier systems had more symptoms in this regard, and the newer systems, the XPS, for example, is better in this kind of matter? This is the first question.
Yeah, it's a good question. So I think the difference is the dysuria and the overactive bladder. Yes, the dysuria, there's much less of that with the new system because, remember, it vaporizes better, and your goal is to be efficient vaporizing. So the 180, using that correctly, taking advantage of that power, you don't get much dysuria at all. I don't routinely give them medicine for dysuria, so they may have a little burn in the first few days, but that's not a big complaint of the majority of patients. The overactive bladder, I don't think that's not related to the laser. That's related to their pathology. So, their bladder. And, to that, I think there's going to be more emphasis in that, and you're starting to see some studies look at that, that bladder preservation or paying more attention to that. I see so many patients in my practice. So I didn't mention before, we're 33 urologists, and we subspecialize a fair amount. So I do mostly BPH. I used to do everything. Now it's fun just doing BPH and men's health and bladder voiding dysfunction in men. But so I've tried every device in some form or fashion, and I'm trying new devices now. And still, I think this is the best. But where was I going with that? So in following these patients, you see them every year and you refill their prescription. I tell them that you're doing okay. If you're happy on your medicine, that's fine, but just pay attention. If you start getting more urgency, more gotta go, gotta hurry up and get there, that's a sign that you're damaging the bladder, and we need to look into it more. How many patients do you end up seeing who have had pills refilled for years, and then finally somebody does a post-void residual, and it's, a liter. We had a guy in the emergency room last week, 5 liters. Yeah, he's not going to do well. But it's important to watch that. And I think, finasteride may have been part of the problem, too. Is starting to get falling in disfavor in the U.S. just because long-term maybe some ED effects, but also maybe some bladder decompensation kind of stuff too. So it's a long answer for your question, but I think the overactive bladder is a whole different thing we still need to learn more about, but that's not dependent on which laser you use. That's the pathology, the disease, I think.
Okay. And how do you compare the symptoms post-operative in terms of how do you compare with TURP, for example?
Yeah.
The laser technique and the TURP.
Yeah.
Do you think the symptoms are going to be the same?
No, I think it's less with the laser. I think the best example was I did this patient. He was a fighter pilot, very tough patient, and I did a TURP on him years ago. I've been practicing now, 26 years, so many years ago. 10 years later, he came back and said, Doc, my symptoms have come back. You did very well with that TURP, but now I understand you do laser. That's the best procedure. I want the green light laser. So before he comes to the surgery and the nurses ask, we have all these protocols, and they say, well, why are you here today? Captain, what are you going to have done? He says, I'm having photoselective vaporization of my prostate with a green light laser. Well, the nurses don't even know that term, so he really researched this. So afterwards, he comes back to me and he says, Doc, that laser was just great. It just was so easy recovering. There was nothing to it. That was fabulous. Way better than that TURP thing before. Well, then he remembered it was me that did the operation. He said, but you did a good job with it. It's just the laser was better. So, I think that really, it was an N of 1, but it was a, controlled over time study. I was doing the most TURPs in our practice before the laser, and I don't do TURP now unless there's a new device or new toy to play with. So, again, just because I thought TURP was more fun, some satisfying cutting the chips. Sorry, Carla, but once you get used to the laser and comfortable with it, that becomes the fun too. But I think it's an easier recovery on them.
And my last question is about the learning curve.
Mm-hmm.
Do you think it's a steep learning curve? How many procedures do you think it's going to be enough for a surgeon with certain experience in TURP to get confident and to perform a good surgery with laser? Right.
No, good question again. I don't think it's hard to learn and much of a learning curve. I think the keys are to start with the smaller, easier prostates. And if you've done a lot of TURPs, that's good. You know the prostate anatomy and what you're looking for and how to get the capsule. But you have to drop the old habits of the trombone in and out. You got to be close to tissue. You got to pay attention to bubbles and the power and all the things we talked about. So if you can do that, I think 5-10 cases you're going to be pretty comfortable with it, and then you can maybe tackle the big median lobe. But just like with anything, if you can do 3 or 5 cases in a row, you learn a lot in that one day. And I teach all our residents to do it, so when they graduate, that's what they're going out and doing is green light. They'll learn their second year, and they'll spend a lot of time with me. I make them go on the simulator first, and Carla will have the simulator off and on or access to. It's fabulous because it focuses on those fundamentals like we talked about, and you can do real cases. You can do 40-gram gland. You can do I think it's an 80-gram gland, a big median lobe. So playing with that would make it easier and help with the learning curve too. But, to Boston Scientific's credit, they're very committed to, they paid a lot of money for this device, and they want it to continue to grow but they want doctors to be comfortable, and so they're investing a lot of money into education and to hence flying me down here to support you doing it. So they will come and help you with it as well. And most of them have seen a lot of cases and can, if we don't let our egos get in the way, can learn from that. But I think it's, if I can do this many and do a good job with them, it's not technically challenging hard. It's just kind of doing the right things to get the most out of it.
Okay. Thank you very much.
Mm-hmm. All right. Thank you all very much. I really appreciate it. Great questions, and thanks for your attention. Thank you. Thank you very much. No, great question. Thank you very much. Hopefully y'all get it one day and get further.